also focusing on the whole thing without losing efficacy. Welcome, Dr. Parveen. So I would now request Dr. Dinesh Talwar to take over and request Dr. Mohit Dogra to join us here.
Hi, Parveen.
Is Dr. Zahir Abbas there? Dr. Zahir Abbas?
I think what we are going to be discussing today is extremely important because any management of ARMD finally relates to trying to increase the interval between treatments. The longer the interval, the better it is for the patient. The question is, how far are we down this path? How much have we achieved? And what is left to be done? And for that, we have Dr. Praveen Sen, who's a senior consultant at Shankar Netralaya, and she will be discussing about Q16 and about what do we know today. Over to you, Praveen.
Thank you, Dr. Dinesh.
Dr. Chetra, could you join us, please?
I thank the AIOC Scientific Committee and my panel here for giving me this opportunity to present something which really interests all of us, and I'll try to show the scientific angle to it. And we know that with the advent and with the discovery of anti-VEGF, this has been a game changer for treatment of age-related macular degeneration. And from 2006 onwards, when we first started the anti-VEGF therapy, to the present times, we are still striving for new therapeutic targets, increased durability of treatment, reduced treatment burden, and improved anatomical outcomes. So with anti-VEGF, first time Anchor, Marina, Harbor, and VEGF Trap, all these View 1, View 2 studies, we first started talking of improvement in visual acuity. But down the line, when we came up with this trial, 7 years down the line of use of anti-VEGF, what happened? So even after 7 years, the patients who were enrolled in Marina or Anchor, which were the earliest studies of anti-VEGF, we saw that almost 68% after 7 years also had active exudation, 46% was still receiving ongoing anti-VEGF treatment, and the moment they were out of the clinical trials, almost 1/3 declined by 15 letters. So neovascular AMD is a long-term disease, and it requires consistent treatment to maintain visual outcomes. If the suspension of treatment is done, within the first year, 41% will have recurrence, and after 5 years, almost 80% cases will recur. And the eyes which resume treatment after having a recurrence have a permanent vision loss of more than 3 to 5 letters. So for treatment of neovascular AMD, the most important thing is prompt diagnosis, treatment, proactive individualized treatment, and continuous long-term treatment in spite of the optimized burden that increases. And this is quite significant not only for the patient, but also for the caregiver who has to bring in the patient every month for OCTs and checkup and injections. And for the society, it increases the cost of treatment and durability of the chosen molecule. These are few questions we have to ask ourselves and answer to the patient all the time. So it is a challenge to maintain the neovascular AMD treatment efficacy while reducing the clinical visits. Aflibercept, with its binding capacity of almost 100 times that of ranibizumab, as well as the fact that it inhibits VEGF as well as the PGF dimer, it definitely translates into a longer duration of action and reduces the frequency of injections and visits. So to test this hypothesis, we had the View 1 and View 2 study, which was a large phase 3 study of more than 1,200 treatment-naive patients, 300 patients in 4 arms, where they tested 0.5 milligram of 4 weekly, 2 milligram 4 weekly, 0.5 milligram of 4 weekly, and 2 milligram of 8 weekly aflibercept. So these were the 4 arms which were seen, and the results were evaluated at 52 weeks as well as 96 weeks. So this is a graph that I have taken from the study. It has shown us that the patients who received any of these 4 arms, they did gain significantly where the visual acuity was concerned, but the 8-weekly arm did not lag behind in the gain of visual acuity as compared to the other 4-weekly arms. And if you look at the central retina thickness, you can see the graph below, and you can see a little bit of zigzag which is seen. That means fluctuation of CRT was seen in the 8-weekly treatment, but visual acuity did not falter, and this fluctuation became even less when we looked at the second year or the 96-week results. So here you can see that the visual acuity gains were comparable in all 4 groups, including the 8-weekly treatment arm, and this was seen at the end of 1 year and 2 year. And importantly, the number of injections came down. While in the first 3 arms, there were almost 12 injections in a year. In the last 8-weekly arm with aflibercept, we had 7.5 in the first year, and in the last year, only at the end of 2 years, only 11 injections, which means actually 5 injections lesser than the monthly arms. So approximately 90% of the patients in viewed study could maintain the visual acuity at the end of 52 weeks, and 48% of the bi-weekly or of the 8-weekly arm also maintained quarterly doses, and they were able to maintain visual acuity even with a reduced number of injections. View 1 extension studies looked at this number of injections for almost 4 years, 212 weeks, and they saw that though it was a capped injection that every 12 weeks they should give the injection, at least the patient should receive it, the visual gains were good, and the number of injections did come down. So the visual gains, even at the end of 4 weeks, even with once an injection in 12 weeks, it was reasonable. So this gave us the confidence to go into a treat and extend kind of a proactive treatment regime for our patients with AMD, so that fewer injections can be achieved. The Altair study looked at the difference in the 2-week extension and 4-week treat and extend study, and this also had almost large number of patients, 247. Here they did treat and extend at 2-week interval and treat and extend at 4-week interval, and they have seen that the visual acuity gain was good in both of them, and the number of injections were also reduced. They were shortened the treatment only if there is persistent fluid or there is a loss of visual acuity and few other criteria which I mentioned here. Note is that the minimum interval was still 8 weeks and maximum interval was 16 weeks here. So once, for the first time, we have used, the study has shown us that 16-week extension of the interval between 2 injections and what happens. So even at 16-week, you can see that both the arms, 2-week treat and extend as well as 4-week treat and extend, both of them had reasonable good vision, and almost 60% of the patients could achieve a 12-week interval between the injections, and 40 to 46% of the patients could achieve a 16-week interval. So we are now at a stage where we can extend the period of interval between 2 injections to up to 16 weeks. And with this adjustment of 16 weeks, almost 96% of the patients could be kept at this injection interval for the second year. So conclusions from the Altair study was that intravitreal aflibercept injection was able to increase the treat and extend period to almost 16 weeks. This is a study which has recently been published in May 2022. So they did a sub-analysis of patients of Altair study. Out of the 247 patients which were included in this study, 90 patients were of PCV. And we all know that PCV can have a very aggressive course, but amazingly, if you see the results, they found that almost 90 to 91% of the patients who had PCV could also be extended, and they could be kept at a 16-week interval, almost in 51. Half the patients of PCV enrolled in the Altair study were at 16-week treat and extend. The next study was the Aries study, and here also they compared the early treat and extend with late treat and extend, but both of them were found to be equally good. Number of injections were more or less the same. After these randomized clinical trials, there were a lot of real-world scenarios, like this study from Moorfields Hospital. They studied the treat and extend for 3 years, and for me, the most important thing was that 90% of the patients could be maintained. 27% of the patients did not need a repeat of injection in the year 3. So if we do a proactive treatment, we can actually in a position at some point of time in some percentage of patients to taper them off. Not only for the patient, but for the caregiver, you can see that the number of visits are much lesser, and so the productivity loss is also much lesser. Because of these RCTs and the real-world data, a lot of meta-analysis has been done, which has included only RCTs and observational studies, and they found that this was extremely possible to have the T&E regimen, which was more useful and led to better preservation of vision and reduced the number of injections. So this is another one. This is from multi-center study in Japan. Almost 50% of these patients, 97 enrolled, had PCV. So this study gives us a comparison between PCV patients and neovascular AMD patients. And you see here also similar has been seen that with treat and extend, number of patients of PCV who could be maintained at 12-week interval is actually 67%, which is more than 51%, which can be seen with neovascular AMD. And they also needed fewer injections over a 2-year period. So what we had initial concept that PCV will need PDT, it with aflibercept monotherapy also, and with treat and extend, we are able to achieve these results. Another very interesting study is to look at polyp regression. So we know as long as the polyps are active, you will have recurrences in PCV. So polyp regression was seen at the end of 3 months with intravitreal aflibercept in 50% of the eyes, and in 40% of the patients who reached, were able to be 16-week interval at the year of 2 years. And the importance of polyp regression, they say, was that the recurrences were much lesser, total number of injections were much lesser, and the mean treatment interval was significantly higher if you were able to achieve polyp regression. So with this RCT, with this real-world data, consensus and guidelines for treatment have emerged from Taiwan for neovascular AMD, and they have said that 3 monthly injections must be given. Treatment should after that be on a treat and extend. You can use a 2-weekly treat and extend or a 4-weekly treat and extend. 16-week interval is permitted and was seen in most of the studies, and they have said that after 2 or 3 consecutive 16-week intervals, if the eye remains dry, you can consider exiting anti-VEGF treatment. Similar consensus recommendations from Asia Pacific Vitreoretina Society, they have said that 3 consecutive injections must be done for PCV eyes. After that, they go into a 2 or 4 weekly treat and extend regime. And then they have mentioned that if you are using ranibizumab, the recommendation is that the treat and extend should be capped at 12 weeks. But with aflibercept, they have allowed the treat and extend to be capped at 16-week interval because that is what has been found to be efficacious. So just leaving you with a couple of examples. This is a type 1 patient which I have been treating. Vision was 6/6, and over a period of time with multiple and intravitreal injections of aflibercept on a treat and extend regime, we have kept, the patient has been able to keep 6/6 vision in the last 4 or 5 years. This is an example. You can see the left eye had a large scar. It's a single-eyed patient, and when it is 81-year-old, and we know increased age is a poor prognostic factor. This eye also had 6/6 vision, but after a monthly loading dose, patient has maintained 6/6. This is 2017. This is 2018. This is 2019. And you can see, though the patient had a little drop due to the COVID, but we were able to bring her back, and she still maintains 6/6 vision at the last follow-up in 2022. Thank you for patient hearing.
Thank you, Dr. Praveen. That was a great summing up of all the data we have so far in our ARSNet. Before we go further and discuss this topic, I think the problem that happens is that very often what is seen in clinical trials doesn't get translated into your clinical evidence when you actually treat the patients. So we have Dr. Chaitra, who's going to be discussing about what her experience, her actual experience with aflibercept is, and I look forward to hear.
Thank you, sir. So my previous experience has not actually been a treat and extend because given the cost of the drug, we never used to follow that regime, and it's really not very practical in our country to ask patients to come on a regime. It's difficult because there are many challenges, and we were discussing yesterday in another meeting too. It's cost, it's the caregiver bringing them, and they don't really stick to schedule unless probably they're on a trial with us. That's the only time they get to come because we're paying for their transport, we're paying for their attenders' transport, and we're paying for their drug, we're paying for their investigations. Otherwise, nobody ever comes on the time or the date that they're asked to come. So with these couple of cases, I don't have too many where I have a very long interval, really a documented interval between the treatment, but since that was the subject, just put together a couple of cases. So this is a 76-year-old gentleman, one-eyed. The other eye lost to a scarred CNVM. He complained of metamorphopsia. The vision was 6/9 at presentation. You can see SREM there, you can see SRF, and you can also see a taut posterior hilot. So this was in March 2017. There was no clear evidence of polyps. This patient, though we did see a leakage on FA, no polyps as such on the ICGA. So this patient underwent multiple anti-VEGF injections. This was in March, May, July. You can see in spite of these several injections, the SREM increased, the PED increased, and then subsequently there was some resolution of the SREM, but then still the SRF remained and even the PED remained. So in September 2017, this was a presentation. We thought, we're missing something. Probably we need a change of diagnosis. We need to rethink. And then we repeated the angiography, and even then you see a well-defined neovascular net, but you can't really see any polyps here. You don't pick up any of those lesions there. So this was in again Jan 2018 and March 2018. You see persisting SRF with increasing PEDs here. So the patient kept coming back. We kept treating with whatever anti-VEGF option the patient took up at that point. And in November 2018 is when we decided that, we'll go ahead with aflibercept for this patient. And December 2018, you can see a very good resolution with the response in the PD and the SRF as well as decreased quite well with the first injection itself. So after the first injection, we followed up this patient Jan 2019 and April 2019. So that's almost, 4 months. There was no recurrence at all, unlike in the previous times when, the recurrence was very, very frequent. Here we were able to push it at least for about 4 months. There was, unfortunately, a return of the PD and the SRF here again. So this was in June 2019 is when the second aflibercept, again you see complete resolution, and we followed up this patient till March 2022. And there has been no, recurrence of the condition. The patient is very happy with the result and continues to follow up because there's been almost a sustained response for over 2 years now. So, like I mentioned, we saw excellent response in a non-responding patient, and especially a one-night patient. We want to give them the best advantage that there is. This is a 65-year-old lady, 6/9 vision. As you can see here, there are multiple polyps. You can also see a BVN. There's a large PD with SREM and notched PDs as well. So here the diagnosis was quite clear. So straight away we went ahead with aflibercept in 2019 Jan. And about 20 to 25 days later, we also, since there were some extra macular polyps, we also went ahead and did focal. We thought we'll get more sustained response if we combine it with a focal laser here. So the SREM resolved faster here than the PED, and also the, if you can see the images on the left are nasal to the disc. You can also see a PED there. That also started flattening subsequent to the aflibercept. So there was no recurrence of the polyps or the fluid or anything after 3 years. There was a good response in this patient with combined treatment for even the extramacular polyps did resolve very well. So I think this was last in 2019. We've kept a close follow-up again. Every 3 to 4 months or any symptoms, we ask the patient to come back to us, has had sustained response. Now, the third patient, a 70-year-old gentleman, left eye vision was 6/12. You can see here again a large PED with SREM, and this case is an example of how one treatment approach really does not work for every patient, whether it is an anti-VEGF or whether it's laser. So since this was a little similar to the previous patient, we thought, there are extramacular polyps, why don't we go ahead and also do a focal laser? Unfortunately, post-focal laser, there was increase in the fluid. The hyperreflective material also increased drastically after the focal laser. So this we restrained from doing any more laser. Of course, it was also very difficult there given the amount of subretinal material there. So we continued with aflibercept with this patient. We took time for both the PED and the hyperreflective material to resolve. And we persisted. This was in March 21, July. We've been giving this patient injections every 2 to 3 months, and the patient kind of maintains with that amount of vision. And since the posterior pole is quite clear, the vision is also very well maintained. So this was the last follow-up. I think the last injection we gave was in Jan this year, and after Jan, we have not had to repeat injections for this patient. This is unfortunately for the right eye. So what I was showing you all along was the left eye. This patient came back in November for the right eye drop in vision, and since we had already had a bad experience with the left eye, we didn't take any risk. We gave one injection in November and the second one in Jan, after which we have really not had the patient come in for a follow-up, probably because of resolution or maintenance of the disease. So this is not like a treat and extend. It's like a patient-opted treat and extend because the patient's vision has been maintained. So bilateral PCV, left eye, subretinal and sub-RP bleed, aflibercept and focal laser, but then we didn't really do very well with the focal laser here. The right eye came with the PCV and SRF and did respond well to aflibercept. So this is my fourth case. This is a 58-year-old lady. Despite this very, scary-looking OCT, the vision is still 6/9 in her. So we again went ahead and we did the angiographies to basically decide, what we're handling here and what to treat the patient with. So you can see here there is both fresh or absorbing blood here. You can see both on the image here. So this is 1 month post aflibercept. So one would expect that it will take time to respond given that there's such a severe disease here. But if you can see in just 1 month, there is extremely good response. The hyperreflective material has coming down. There's also, an amazing improvement with the PED as well. So we tend to worry as to whether we should even treat these patients or not. But given the fact that the patient had extremely good vision and we don't want it to worsen, I think we did well in giving this patient any treatment and it did well. So after the second aflibercept, again you can see resolution, and this sustained for almost 18 months just after the second injection. This is our last follow-up of that patient. So what we've seen in our series, what I've observed is that those patients with PCV and massive subretinal and sub-RP bleeds, vascular PEDs, aflibercept or in combination does work very well. Again, with a lot of SHREM, we've seen good response. We always thought that SHREM is a bad prognostic indicator, but I think these couple of cases shows that actually SHREM can also go away with good outcomes. We saw sustained response in most of these cases with just 2 to 3 doses of aflibercept and a treatment-free period for more than a year. Thank you so much.
Thank you, Kshetra. Basically, most of your patients have been on PRN treatment.
Yes.
And actually, you have torn to shreds the concept of a treat and extend. Because I was going to ask something else, but now my first question is, should we start off with PRN or should we start off with treat and extend when we start treatment? Praveen? Because since there are a large number of patients who may end up with a huge, huge time gap before they get a recurrence. The question is it, in her first patient, the patient if got 2 injections, and in the same period, if we had put treat and extend, she would probably have got 10 injections. Now, is it worth subjecting, and especially in a country like ours, is it worth subjecting patients to 10 injections? Or I'll give you the alternative. Put the patient on PRN and see the time it takes for the patient to get recurrences. And you can do that over the next 2-3 injections, and you have a fair idea how much time is occurring. And then if the patient is requiring injections more frequently, you start with the treat and extend. And if it's already a huge gap, you maintain the gap which you're getting. So that means you cut short the period to a treat and extend.
So I think I understand your question, and I would probably put it as, I don't like to use the term PRN. I would say we use a combination of treat and observe and treat and extend. So if you really feel that, sometimes a very tiny CNV, you've given 3 loading doses, or sometimes you may even see 2 loading doses and the patient is doing well, especially if it's a small, early type 2 lesion, which is where your biomarkers also come into play, your clinical judgment comes into play. You think that now I have that much body of experience, you know which one will go which way. If you want to first give treat and observe, you do one step of treat and observe, see the patient again. But then straight away don't call 4 weeks or straight away don't call 16 weeks later.
No, you
we
call
call
4
4 weeks later.
No, I'm sorry. The
Exactly.
follow-up in all these cases would be 4 weekly.
Yes. So if
The
we are going to...
treatment would be given PRN as required.
Yeah, so you
And
can reduce
Over
the
a
number
period
of
3
injections.
months, you have an idea how much.
Yeah, if you reduce the number of injections, you have to compromise that you have to increase the number of visits.
Yeah, I think one problem that's happening with concepts of PRN is to increase the interval. Interval increase comes after 6 months of no treatment. It does not come in the beginning. So that's the important thing.
Yes. So if you are doing treat and observe, then you can have to, the next visit has to be 4 weeks. Then it can't be 12 weeks.
Yes, so follow-ups 4 weeks, treatment as required, determine the kind of interval you are requiring, and start short of that. Yes, Raja?
Mike is right behind you.
Can we get a mic for him? Can we have a roving mic rather than...
So even what you are saying about increasing the interval after 6 months, it's probably 6 months of inactivity. A person who
Yes.
has been receiving injections multiple in the first 6 months.
It doesn't work.
Yeah, you still have to call them every
It
month.
comes monthly. Only if you have 6 months of inactivity, then you can increase the intervals 4 to 6, 6 to 8, 8 to 10, up to 12 weekly. But 12 weekly intervals never go away.
Yeah, but the biggest point which you have made, everyone should understand, that's the major problem in giving out this concept of treat and extend PRN, is that in PRN you have to come every 4 weeks.
Yes.
And that has to be understood by everyone, and that is not a free visit.
Yes.
It has indirect cost.
Yes.
And that is why you are looking at treat and extend. Now, I think Dr. Talwar has told very clearly many years ago, if the injection is being provided free by insurance system, then the cost of the visit is much more than the cost of the treatment.
Yes.
Whereas if it's a cash pay patient out of pocket, the cost of treatment is much more than the cost of the visit. So you have to judge that and take into account which one is going to be more cost effective, but the overall point is PRN means the patient has to come every 4 weeks.
Follow-up
we
is
have-
4 weeks.
yes.
Actually, she's made the point very clearly. You see, 2 injections versus maybe 12 in the same period with the same results. So, and the number of patients who will be getting these extra injections in CNV is something like 30 to 40% of patients. So that's a huge number. Yeah.
So if you, sorry.
Dinesh, Praveen, and everybody, the panel, I would like to ask, do you feel that the response is different in patients who have primarily a subretinal pathology like in PCV, with or without hemorrhage and Shrem, or those which have intraretinal edema? And would you differentiate these patients in the loading dose concept?
Yeah. Okay,
I think
so,
I
you
will
know,
definitely look at what pathology I'm doing and then only decide on treat and observe or treat and extend. But as Dr. Raja mentioned, if the patient is outstation patient also and he has to come so far, then treat and extend works best for him. In our scenario, when patients are traveling for so far, they said, okay, now we have come, at least give us injection, next time we will come 6 weeks later. So it works, they also understand, we also understand.
Unless
But
the
if
patient
it
is
is a-
traveling
Point out here.
to Chennai from Ladakh,
Yes.
the cost of treatment is higher than the cost
No,
of
but
the...
they take leave, they come off, various
Yeah.
things are there. So
but
that,
basically, one more point I'd like to raise, you know, there is a tendency to say all CNVs are the same. The fact is it's not so. Type 2 CNVs will respond very well even to ranibizumab. They have an excellent response to any anti-VEGF. Most of them will respond within 3 injections. So to club them together doesn't make sense. And I would actually, sort of want Raja to maybe do a VRSI survey and check, is there an actual difference in their response? Then why should we club them together? We should actually create paradigms, algorithms which are separate for classic and occult.
So there have been numerous studies which have shown not only classic and occult, type 1 behaves differently, type 2 behaves differently, type 3 behaves differently. So this is where you use your clinical judgment and your biomarkers.
The point is
and
the
then-
studies don't do that. Why
There
don't the
is-
studies do that?
So there is a sub-analysis now coming. So they have done type 3 analysis separately, and they have said that these do respond to lesser number of injections.
So what,
So
what
all this is
Dr.
happening.
Talwar is asking is that we are talking about ARMD here right now for
Yes.
treat and extend, not for myopic
Not
CNM,
myopic
other
Not
type 2
myopic
CNM.
CNM.
Because ARMD typically
ARMD,
come either
yes,
minimally
type 1,
classic
type
or
2,
occult
type
with no
3.
classic. Very few are predominantly classic. So that's what type 2, type 1 is, just for that class.
There is a small segment of ARMD also which has type 2.
absolutely.
Yes.
Yes.
Sorry, just to kind of, take the discussion back to, unfortunately, this is me, and you'll all have to bear with me for 1 second. The evidence base that Dr. Praveen Sen showed was actually grade A evidence. And I think she's very nicely demonstrated that I think this is the way we need to treat our patients. We can all deviate because of circumstances, economics, region, etc., etc. But I think the gold standard of treatment today, whether it's Moorfields, whether it's Bascom Palmer, whether it is any of the big centers in the world, whether it's Shankara, whether it's my practice, I'm not a leading center of the world, is treat and extend. We'll always have one case. I can show you one case which is done very well with one injection. That does not become the evidence base. So everyone who's sitting here, unfortunately, Chaitra followed kind of with Dr. Sen. I don't want people to get confused. I think all of us sitting here will totally agree that if I had AMD today, I would not kind of want a one-off injection and then, we'd all go with the treat and extend approach, because I think the risk of recurrence, as Dr. Sen very correctly showed, if you look at the Ortiz study, a lot of people who went to 16 had to be brought back to 8 as well. That means that there was a recurrence. So if you're thinking that one patient is going to be out to 16 weeks and stay there for the rest of their life, about 40% of patients who went to Q16 had to be brought back, because once they went to Q16, if they had a recurrence, they came back to Q8 and stayed at Q8.
Yes.
That shows that there's disease activity in these eyes. These are not benign eyes. If a PCV bleeds while you're extending, monitoring, PRNing, whatever you're doing, you could knock that patient from 612 to counting fingers very quickly. Bailey has showed very nicely that at least in PCV, one-eyed patients, a constant injection reduces the risk of a bleed and loss of vision. So I think, in a one-eyed patient, I think a treat and extend or something more rigorous is definitely very advantageous. And in a city like Bombay, Chennai, Talwar Sahab, yourself, if a son has to take leave to come and bring the parent to the hospital, there is half a day, there's a huge cost to it. I think treat and extend, the advantages are really big. So I think Chaitra, one case will do great, but I think evidence base today is yet treat and extend.
I agree and thank you for putting it together
Yeah.
very well.
Nishant, I think you will have to come back. So there is one protocol we never discuss. It's not even touched, but it was part of the View 2 study second year, capped PRN. So when you are talking about treat and extend, you are still not getting the patient into your clinic every 4 weeks. That's a very, very important thing. So even if we are talking about treat and extend where the patient is not being called back every 4 weeks, why can't you use a capped PRN if you are so worried about, getting a patient having bleeding earlier, right? It's still a proactive regimen. It's not a reactive regimen.
Most of the studies have used capped PRN
Okay,
actually.
I think
Initially,
we will not
capped
discuss this point,
PRN.
because this point, we are just repeating the same things again and again. Let's come to,
So I have just one question for the panel. Sir, I think we all agree now with treat and observe and gradually increasing and decreasing the duration. So once we reach 16 weeks, sir, what is the end point?
Yeah, I'm
when
coming
would
to
we
that.
like to stop the treatment?
Thanks,
Because-
Bhuvan. This is exactly the point
So
I'm
this
now
is
coming
one of the consensus which I had shown also, the consensus and guidelines which have been put up by the Asia Pacific Society. So they have said that 16 weeks interval, then 2 or 3 injections at 16 weeks, and then you try to withdraw and see whether any recurrence happens or not.
Okay,
This is
so-
one. The other one is the futile lesion. How do you label something as a futile lesion? That now you have kept the patient on treat and extend for a long time. Lesion is very big. Visual acuity is not improving. Withdraw the treatment. And if there is no further drop in vision, that means the anti-VEGF is not really doing any further benefit and the patient may not visually improve. So then again you stop. But if there is drop, then you have to restart. So
ma'am,
these
so
two
after-
things have come
after
We
recently.
are
giving-
talking about stopping the treatment at 16 weeks after giving 2 injections.
Yes.
If there is no,
That is the
after
guideline,
that,
yes.
and then seeing, and then just doing the patient
So
follow-up.
we'll keep the
Now,
follow-up every
please
month?
keep it, no, but
No,
before
no.
you come, just keep it in mind, the Altair study is a very aggressive treatment study. I just want you to realize this because it shortens the intervals even for persistent CNVM. If there is persistent fluid, the interval is shortened. The interval is increased only in the presence of a dry retina, which means when you say 16-week interval was reached, it means it was a dry retina. When you give your second 16-week interval injection, it means now the patient has been dry for 8 months. So keep that in mind. This would not hold for patients who are stable and not yet dry, because they would not, according to Altair, ever reach 16 weeks.
So
They
is
would
there-
not be allowed to
Is
extend.
there any role of increasing the duration further from 16 weeks to 20 weeks and then stop it?
No, so that's exactly the point.
You
That if
take
you're
your call for
16
that,
weeks,
I
you've
think.
got a dry lesion, and twice you've got that dry lesion, you've got 8 months of without any problem. So that is where you can follow up. Yeah.
Talwar sir often mentions that these patients, you need to actually tell them that either you die or I die, and that's how it goes.
Yes.
Because I've burnt my fingers with these exit strategies where I have gone beyond 16 weeks and then I've stopped, and these patients have actually lost vision, come down to finger
Yeah,
counting.
so
from
the
6 months.
follow-up doesn't stop.
Absolutely. So
See, the treatment is stopping, the follow-up is not stopping. So that is the difference.
And even after, going for a 16-week injection interval, the patient has to come actually earlier. If you really want to do justice to that patient, it shouldn't be 16-weekly, interval of
Yes.
checking up.
Now, the other important thing I'd like to raise, how many patients? We are talking of only 40% of patients. This is only 40% of patients who reach 16 weeks. There are 60% patients who still need management. What are we doing for them?
We need to find alternative drugs and therapies. We need to find alternative treatment modalities.
What?
This is not perfect, so research has to continue. Like you have long-term duration acting, we have the injectable, the port device, various things. So this is not the best, the treatment, ideal treatment, but this is what we have as of now.
See, the reason I'm asking this is the Altair study did not allow an extension if the patient had persistent fluid, not increasing fluid, but persistent fluid. Would we consider, I'm asking the panel, would we consider extending the duration in patients who got stable fluid, not persistent fluid, but absolutely stable, no change in OCT, no change in vision? Would you try to extend in these patients?
Actually, the criteria of retreatment or shortening treatment is increase in CRT of more than 100 micron. It is not an absolute any increase. A drop of letter of more than 5, increase of more than 100 is
100
what has
microns
been
is
used
what
in
I-
Altair.
Indication for shortening. I'm talking of
Yeah.
increasing. No, I'm saying you've got a patient who's not changing the fluid. The fluid level is staying constant. You're at 8 weeks today. You've given 3 injections, no change in the fluid, no change in the vision. Would you consider changing to 10 weeks now and seeing can we maintain the same thing on 10 weeks?
So I
And
think
maybe
the
we can
last-
maintain this stability at 12 weeks.
So this is the setup that we see in the clinical thing also. We are not always measuring the CRT and then taking a call. We look at the visual acuity, patient is stable, and we then take a call and extend. So it's sometimes you cannot measure 100 micron and then follow Altair, that Altair told me this, so I'm not going to do that. But clinical judgment is always,
Mohit, would you
you know,
add like that?
So I think in that context, instead of a 4-weekly extension, you'd go to a 2-weekly extension,
Yes.
because you would want to be a
Yes.
little more kind of circumspect.
Absolutely.
And because the 4-weekly then would, I think, be jumping the gun.
Yeah, so the basic point is, you see, even eyes which have stable fluid, the Altair study gave you a situation where it was very, very aggressive in its treatment. But I think we should consider in these patients who have stable fluid, stable vision, you increase the duration by 2 weeks. And if there is no change, You can continue for 2 weeks, then increase by another 2 weeks, till you determine the level at which the patient is actually getting the recurrence or an increase. You may be able to extend many of these patients to maybe 10 weeks, maybe not to 12 weeks, maybe not to 16 weeks.
So I'd just like to add, I think we should increase by 2 weeks if it is stable, but it also, you have to be careful about the type of the fluid. I think a subretinal fluid is the one which would be more acceptable.
Yeah.
And there are also some studies which say it is probably protective also and the vision is also better. But if there is an intraretinal fluid, I think you have to be more careful.
But it doesn't go away.
Yeah,
If it's not going away, that's the point.
So you have to either treat it again or whatever, change the drug, or I think the intraretinal fluid should not be tolerated.
Okay, if you want to change the drug, that's the next
It should not be tolerated. My point is, we should be careful about the intraretinal fluid.
So this is the case where I think OCT-based, thickness-based treatment decision making, we moved away from it first time in CAT trial. You don't look at just the thickness, ETDR as grade. Any fluid you treat. And what Bhuvan pointed out, if at all you want to look at a stable fluid, there is a case based on evidence that you may want to differentiate whether it's intraretinal or subretinal fluid, but if it is subretinal fluid, you are still allowed an extension like as if there were no fluid.
Let's say
but if there is an intraretinal fluid, there's no way you can extend
the
it.
Hawk and Harrier allowed you, the Altair did not.
Yeah, so I would probably at this time go by the evidence that any intraretinal fluid cannot be tolerated. This patient will be at risk for vision loss.
But the reason I'm mentioning is because there are patients who have intraretinal fluid which becomes stable. So when you reach that level, there is no harm considering that whether this is staying stable at a little higher interval.
Yeah, it
You
may
don't
be,
lose anything.
but
If it's a 2-week interval that you increase, you don't lose anything. Yeah, okay. Okay, one last thing which is important, Altair used 2-week extensions and 4-week extensions. Praveen, what would you advocate?
So again, case to based, you start with a 2-week extension, and then if very quickly you can move on to a 4-week thing as well. So which is the recommendation also, that either 2-week or 4-week, depending upon your clinical judgment, how stable the patient is.
The thing is, the reason why I asked this question is because the results of 4-weekly extension are not as good. And then you see, if you see, there are two aspects. One is reaching 16 weeks. The second is maintaining 16 weeks. If you do 2-weekly extension, the patients who reach 16 weeks maintain that extension. If you do 4-weekly extension, they reach it once and they regress. You know, the figures are something like 54% reaching. It comes down to almost 40% are the ones who maintain it. Ultimate maintenance is the same 40% in both the groups. So it's better probably, I would suggest moving at 2-weekly extensions, a little slower, like a tortoise, and coming to the right point. You'll come to the same point, but probably without any regressions. So that's one important thing. Any comments?
I agree. I do 2-weekly.
Yeah, okay. And Dr. Dogra has told us to get out, so.
Yeah, thank you very much.
So we will stop over here, and the rest of the points can be raised
We
later
won't
on.
extend it anymore. Start करें? I think we had a very heated discussion in the first half, and I hope second half will be much cooler, because primarily we have a discussion on diabetes, which is not so demanding as compared to RMD. And I was talking to Mangat. You see, it's always better to go slow. We always write follow-up per se 2 weeks /SOS, and I still believe patient home monitoring vision metamorphopsia can, and it will not make. And whatever bleed, occasionally with injection also it can happen, or without injection, the incidence is not too much of difference. Okay, in any case, compared to AMD, DME is more forgiving than AMD. AMD is more VEGF load there. So we'll begin with our star speaker, Nishant, and one of the most lucid, messages he gives. And his talk will be primarily on can early and intensive treatment reduce the burden?
Thank you so much. It's a wonderful pleasure being here. First of all, welcome to all of you to Mumbai who are not from here. It's wonderful to have you here. And we're very proud to have the Geo Center here, which I think is one of the world's best convention centers I think there is. This is a topic where I'm very scared because I know that Dr. Verma has some views on it, etc. So it'll be great debate, but let me put the evidence to you and then you can decide. So financial disclosures, I do get research and travel grants from almost everybody who exists. There's no doubt today that the gold standard for treatment in DME is an anti-VEGF. No matter which study you look at, no matter which drug you look at, for the first time we're seeing a significant number of people improving in vision, and that's kind of, 2 lines on Snellen or more, and more than 90 to 95% of people stabilizing the vision. So I think today, anti-VEGF treatment for DME is the kind of known thing. Let's look at some of the lessons we learned from the earlier DME trials. Well, the Rise and Ride was a monthly ranibizumab trial, and what you learned with intensive treatment given almost for a year, you can see that the vision improves and stays improved. So that was the first time that we actually saw vision improvement at this degree. But the other thing I want you to see is that actually the vision improves after the first injection, but it does continue to improve. That graph kind of has an upward trend for a few more injections after that as well. The second thing we noticed is that if people who did not get the injection in the first 2 years were then swapped over, their improvement is not so good. So we always think of DME as being a forgiving disease, but it isn't that forgiving because the visual results, if you don't treat early, do tend to suffer. And the third thing we see is that if you've treated these people kind of quite aggressively and then move on to an open label extension, when I say open label, that basically means that people are coming in and going so that the follow-up is a bit poorer because it's not a clinical trial, as Chaitra very nicely said, that when you're paying for their transport, etc., your compliance is better. But if you treated them aggressively over a period of 2 years beyond the kind of open treatment, you notice that the vision remains maintained. So you do get some benefits of early treatment, even later on in the course of disease up to 5 years, right? So that was kind of something that was interesting. The other thing is that, oh my God, if you're giving monthly treatment or if you're treating so aggressively, you're going to treat too much and the number of treatments is going to be crazy. The DRCR network study showed us that the average number of treatments, even with intensive early treatment, was about 8 to 9. That halves, or less than halves, to about 3 to 2 in the second year, and even kind of reduces further in third year. And the same thing we saw in Restore, where the early treatment is about 8 injections in the first year. It halves in the second year, and then further halves in the third year. So the number of injections goes down, though you're treating quite aggressively in the first year. In the open extension of the Ride and Rise, what you notice that actually 25% of people did not need any treatment at all. That means if you hit it hard initially and get that edema down, you're going to get the benefits much later on. And the average number of injections over a period of time was less than 3 a year, which is quite manageable. Then, of course, came aflibercept. Now, you all know about this drug. It's like preaching to the choir, but it does act against all VEGF-A, all VEGF-B, and placental growth factor, which is an advantage it has over the other drugs. And, of course, most of us out here will know that the potency of the drug against the receptor is almost 70 times greater than ranibizumab, which is the other licensed drug for DME, and about 100 times more than bevacizumab, which is the off-licensed drug. So, in theory, this is a much more potent drug. Let's look at the clinical trial data. At this stage, you'd expect me to talk about Protocol T, but I'm going to save that for later. Let's look at the initial study with Vivid and Vista, which were the first trials done for DME with aflibercept. What you notice is that this was laser versus aflibercept versus 2 dosing regimes of aflibercept. So 2Q4, which means every 4 weeks, or 2Q8. The thing to remember is that all eyes actually got 5 monthly injections to start off with. So that's an important thing I want you to remember. And after 2 years, the laser arm could be swapped around. So let's look at this result. It's a crowded graph, but I'll try and put some boxes up. So first thing you notice is that the vision is fantastic. You get 2 Snellen lines or more than 10 letters of improvement, which we'd never seen before. Now, as I told you, everybody gets 5 loading injections. And if you look at that dotted line, what that's showing you is the graph that after 5 dotted lines, most people have completed their ascent, and then they're plateauing out. So if you gave only 1 or 2 injections, there'd be part of that ascent that you would have missed out. So 5 monthly injections, what it does is it gets you to that plateau level where the vision is going to be very, very good. And then after that, whether you go 2Q4 or 2Q8, even if you extend the interval by double and make it every 2 months, you notice the vision doesn't change. So that early intensive treatment gives you the maximum benefit you're going to get. And then even if you can reduce the burden of treatment, you maintain that vision because it's the first 5 injections that get you that maximum benefit. You're squeezing the eye out for the maximum benefit. And of course, this study showed us that if you wait for 2 years in the laser arm and then swap, the vision is really bad. So though it's a forgiving disease, it's not that forgiving. If you look at Protocol T, all of you know about this study. It looked at ranibizumab versus bevacizumab versus aflibercept. Just remember that, the ranibizumab used was 0.3. That's because that's what is licensed in the US. Nowhere in the world was 0.3 available. And the Rise and Ride shows us that 0.3 and 0.5 were just as good. Now, this was a PRN regime, but the thing is that it was a strictly controlled PRN regime. That means that you had to kind of continue to get injected if you were kind of showing any signs of improvement or worsening. So obviously, it makes sense. If you're getting better, please continue injections. If you're getting worse, stop. If there's no improvement or worsening, but you'd achieve normal vision, which is 6/6 vision, that means you squeeze the eye out and you're back to normal, the treatment could be deferred. What happens if the vision did not become 6/6? Well, then if it was below the 6-month visit, you needed to continue to get the monthly injection. That means that if you hadn't achieved 6/6, till week 24, you would get an injection mandated because there was yet that hope that you could squeeze a little bit of extra vision out of that eye. So effectively what this meant is that most people got about 5 injections and then they moved on, right? So this is the label in Europe. It's 5 monthly dosing and then Q8. We can argue about whether this is a dosing regime suitable for India or not, but this is the clinical trial data that I'm showing you. We all know this graph, so I'm not going to waste too much time, but aflibercept does tend to do better at 2 years as well. And if you look at that graph of ascent, it rises more rapidly. That means the patient sees a more rapid improvement of vision, and it goes higher. That means you're getting a better quantum of improvement as well. If you looked at people with 6/12 vision or worse, in the first year, we all know it was statistically significant. In the second year, that statistical significance was not there, but yet aflibercept was giving you better value for money or better bang for buck. But you need to look at area under the curve. If you look at area under curve, which is a much more scientific way of looking at this data because it tells you what is the overall journey of the patient over 2 years rather than what happened at one point of time, because that point of time is data carried forward. There are lots of statistical ways to make up for missing data. This tells you on average what happened, and obviously in this case, aflibercept gives you almost 1 Snellen line better than the other 2 available drugs. Number of injections, as we've seen, though you're giving very intensive treatment in the first year, average number of injections about 9. In the second year, it drops down to half of that, about 4 to 5. So over 2 years, you're looking at about 14 injections to get really good visual results. Now let's look at some really kind of new data about early intensive treatment. If you look at this graph, if you'd given 3 injections in Protocol T, you would yet notice that about 50% of people, even in the Eylea group, would have had persistent macular edema. But if you gave 5 injections, then that number of people who had persistent macular edema drops down to 31%. That means from 50%, you get another 20% of people who will not have any persistent macular edema by giving 2 more injections, which I think is worth fighting for. If you look at the proportion of people who continue to improve, because I told you the Vivid and Vista trials told us that, listen, you have to give 5 monthly doses. So let's see, at 0, that means at 0 you got injection 1. As you'd expect, about 59% of people got an improvement of 5 letters or more. After the second injection, that goes up. After the third injection, 16% of people got an additional 5 letters. Now, if you had stopped there, what would have happened is that this proportion of people, which is 14% after the 4th injection and another 14% after the 5th injection, you would not have given them the benefit of 1 Snellen line. 1 Snellen line is very, very important in people who have a chronic condition and anything can happen. So in this case, if you stopped at 3 injections and did not continue with the early intensive treatment,
30% of people would have not got that benefit of an additional 5 letters, which is really, really important. If you look at this from another perspective, we want the OCT to be better. As Raja was telling us that, we don't look at kind of CFT, we look at fluid today, and I completely agree with him. But after the third injection, so you gave the third injection, 20% of people got an improvement in CFT. After the fourth injection, another 16% got an improvement in CFT of about 10%. And after the fifth injection, another 12%. So if you'd stopped at that kind of third injection, not continued with your early intensive treatment, 28% of people would not have had that benefit of the OCT and the fluid going down. Let me look at this another way. If you look at people, what happens is a lot of times we see this. You give it 2 injections, the vision has gone down. Most of the times that people start then saying, swap the drug, let's give an injection, let's do an OCT, let's see if there's some traction, maybe surgery. But in the studies, that wasn't allowed. So if you just continued giving monthly injections, this group of patient also does really, really well. They turn a corner and they do very well. So at 1 year, 8.8 letter improvement. At 3 years, 11 letter improvement, just by continuing to give the anti-VEGF intensively and aggressively. Let's look at some data which comes kind of, from Protocol T. If you look at this line of 3 injections, you'll obviously see that there's that dark blue line. They've kind of almost reached their peak with 3 injections. But there's that light blue line which is improved but hasn't yet peaked. It hasn't got all its benefit yet. And that red line, they've actually done worse. Now again, of this course, no swapping of drug allowed, continue. If you gave 5 injections, the group in the blue line would continue. So maybe you'd say, Dr. Kumar, didn't you overtreat this group? But the light blue group continued to gain about 3 letters. And look at that red group, which you said was a goner, it's a non-responder, will not do anything. They've improved by about 4 letters. And over time, with that early intensive treatment, they maintain that visual improvement. Now, you don't know which group that patient is going to come into. So effectively, if you look at it, there are 3 groups. After 3 injections, they achieve their maximum response. That's your A+ student. That's great. The group 2 is the one who starts improving but needs a little bit more treatment, a little bit more aggressive early treatment to get their full visual potential. And there's a third group. After 3 injections, they've actually done really badly. But with 2 more injections, just a little bit more perseverance, they swap the corner and they do so well. So there is a subset of people who we traditionally thought were not doing well, but with early intensive treatment, they're going to do really, really well in the long term. And therefore, I think it's important to understand that unless you get 6/6 vision and a normal fovea, early intensive treatment is recommended. I'm not going to step on Darius' shoes because I think this is his next talk, but because this comes from Moorfields and I was an alma mater there, I was a consultant there, this comes from Phil Hyken's group, effectively they follow 5 monthly injections and Q8 and look at the vision improvement, 13.8 letters. I'm going to let kind of, Darius wow you with this study, but effectively what it tells you that the number of treatment with time, despite giving such intensive treatment in the first year, goes down dramatically. From 7.6 in the first year, out of which 5 were mandated. That means only 2 extra. In the second year, it goes down to 2.7. In the third year, about 2.9. So early intensive treatment gives you dividends later on. So what does the evidence suggest? Early intensive treatment produces the best results long term. Up to 30% of eyes with DME, even after the third injection, if you give them a 4th and 5th injection, they will get a 1 Snellen line improvement, which is worth fighting for. You will get kind of then, once you've kind of done the early intensive treatment, you can go to 2Q4, 2Q8, or treat and extend, and you really don't lose that early benefit that you've got. Loading dose. This is a very loaded term. I think, it causes a lot of confusion, causes a lot of debate, causes lots of angst, and I think it causes a lot of divide. It's misused, misunderstood, and misquoted. So I think if we stick to early intensive treatment, maybe that's better. Treat till the vision becomes 6/6 or the OCT is normal, because that can be achieved in DME. Or, if you feel the vision is not improving to 6/6, look back and say, is there some convincing structural evidence to suggest why it will not become? Is there ischemia? Is there some structural changes? If that is the case, then after 2 consecutive injections, the vision hasn't improved, you can say that, listen, maybe we can step off the gas now. But I think you have to be aggressive. There's no fixed dosing that's going to be applicable to every eye, as all the studies have shown us. Some eyes will get a great result and peak after 3 injections. Some of them are going to need more than 3 injections to get their best result. And some of them are going to do badly after 3 injections, but with 2 more injections, they're going to turn the corner. So I think the intention is to treat aggressively every 4 to 5 weeks till there is yet some scope for improvement. Try and squeeze the eye out. Try and squeeze that fovea out for the maximum vision, because early intensive treatment is going to give you that bang for buck. Ideally, aim for 6/6 and a dry fovea because in DME that is possible. And sometimes we notice in CNVs that's not an option available to us. The number of injections, even if you're super aggressive in the first year, all the trials, all the evidence suggests the number of injections goes down with time in the second, third, fourth, and fifth years. I've heard people kind of saying, I get second references, I'm sure all of you do, that some doctor told me 3 injections are going to be enough. I think this is the biggest myth, and I hope it's a myth or it's the biggest deception. So either people are fooling their patients or fooling themselves, or they genuinely don't know. Because I have not found one study that has actually told us that 3 injections do anything for DME long term. Even when vision was 6/6 in one of the clinical trials, which said good vision, let's treat with an anti-VEGF, the mean number of injections was over 2 years was 8. So even when you have 6/6 vision, if you start on the journey of anti-VEGF, it's a long journey which requires treatment. Just to leave you with the thought that I run a charitable foundation called IBTs, because diabetes blinds. We've got 3 Guinness World Records. Since you're in Mumbai, I thought I'd show you some slides of our celebrities who support diabetes and blindness, but we've run out of time. So I'm going to skip that and thank you very, very much.
I think we'll have a discussion at the end also after Dry's. Where is Dry's? Yeah. About real-world experience. Because to me, honestly, real-world experience is more important than whatever trial tries to push.
Mic nahi chal raha? Yeah. So that's a tough act to follow, Dr. Nishant. So I'll just speak a little bit about the real-world evidence. So like Dr. Lalit just said, the clinical trials are based on these strictly defined protocols. And they have a lot of exclusion criteria which we may not see in our patients, like patients with poor glycemic control, active PDR, etc. So in the real world, these patients are what actually come to us. So the protocol which strictly determines time frame for follow-ups, all this may not be so relevant for our setting. So although we are going to translate the clinical trials to our kind of clinics, let's look at the efficacy of the intravitreal aflibercept for treatment of center involving DME in a real-world setting. So we just heard from Dr. Nishant the key messages from the clinical trial. Aflibercept is indeed the choice of treatment for patients' vision acuity worse than 69 ETDRS letters. That's less than 20/40 due to DME. And this has been shown by Protocol T, and there's no doubt about it. The molecule has been designed to trap VEGF and PGF, which occur at very, very high levels in these diseases and have a pathology and are important for DME. So this is the reason why. There's also a disease-modifying role, which is important when we use this molecule. And as we just learned in great detail, intensive treatment in year 1 can modify the underlying disease and improve the long-term visual outcome. So now, along with this trial, let's see what is the real-world evidence which is emerging, which will kind of support this and help us in our clinical practice. So I think the company also is supporting multiple real-world studies, and these, as you can see from this slide, they are across the world. There's none from India, so when I pointed out to Dr. Prachi and team, they said they would consider it, but there's none of these right now currently in India. So there's good evidence from one of these trials which was held in France, and this showed that treatment-naive patients who received the 5 initial doses of aflibercept gain numerically higher vision gains than those who don't. So this is what always we are taught about the pathology, that initially you have to give 5 injections, and this is supported by the real-world evidence. I think Dr. Nishant just spoke about this. This was at the Moorfields Eye Hospital. And again, even these authors say the purpose of the clinical trials, that there are various reasons. Patients may have multiple doctor's appointments. They are the diabetics, unlike the AMD patients, are the working age group population. So they don't comply strictly. And they did this trial because the strict regimen is not possible to replicate in the real world. So they wanted to kind of find a way to pragmatically deliver effective therapy, which was practical for their patients. So even this trial showed that aflibercept was associated with meaningful vision acuity gain and avoided loss of vision in the real world condition. And what they found also, which is interesting, that patients who presented with poor baseline visual acuity are constituting the majority of patients who come to our clinic. So they kind of echoed what Protocol T showed, but that also in a clinical setting and not in a clinical trial. The visual gain also was excellent in all the groups, and this is what Dr. Nishant also showed, the wow factor. In the first year, 7.6 injections were the mean number, but just look at the data after that. 12 to 24 months, only 2.7, and 24 to 36 months, only 2.9 injections were needed. So hit it hard initially, and you'll reap the benefits later in year 2 and year 3. I think that was a kind of pivotal message from this trial. There's also an interesting FRB, the Fight Retinal Blindness Registry, which is there in Australia. And they also kind of compiled this data of patients who had less than 68, so that would roughly be 20 by 40. And they also they compared the two molecules, ranibizumab and aflibercept, and they found significantly greater vision gains in aflibercept. You can see this is a plus 7.6, whereas this was plus 10.6 letters. So now we come to an RCT. So this is, of course, the highest level of evidence. So this was a RCT published in the Cochrane database review. And this included a large number of patients. There was more than 6,000 patients, 24 studies. And they found that at year 1, all efficacy outcomes favored aflibercept over the other molecules. Patients were approximately 30% more likely to gain more than 3 lines with aflibercept compared to other molecules. And for every 1,000 patients with aflibercept, 92 fewer would gain 3 or more letters. So this would be roughly 10%. So even a 10% patients doing better than the other molecules is a significant number. So again, this is another slide based on the Cochrane metadata the database. So they said they were more effective. Of course, first they compared these to laser. So all the anti-VEGF agents are more effective than laser at improving vision. This is no rocket science. I think we all know that. Patients receiving aflibercept are more likely to gain more than 3 BCVA at 1 year compared to the other molecules. And I think at 1 year, patients receiving either ranibizumab or bevacizumab had lesser change in vision and lesser CRT change compared to aflibercept. So here you can see that ranibizumab versus bevacizumab seems almost same, whereas aflibercept is superior to both these other molecules. So the certainty that they are more effective than laser, that is high, whereas the fact that ranibizumab and bevacizumab did not differ is moderate. What do the various retina societies across the world say? So these are some guidelines from Euretina. Then there are some guidelines from Australia published in Clinical Experimental Ophthalmology, guidelines from Canada, and guidelines from the German Society. The Euretina guidelines provide expert opinion regarding this, and they have said the use of ranibizumab was most likely to result in the same activity after 2 years as aflibercept, so this is similar to Protocol T. But the effect will be reached in a slower manner. So therefore, they recommend it should be started with aflibercept if it is available for these patients. So again, similar message that if it's worse vision eyes, we should start with aflibercept. This is some data by Dr. Jamie Chung's group, and this is Asian data. And this is based on evidence-based collected from Asian country. So the message is quite clear. The choice of the anti-VEGF should depend on the baseline visual acuity. And again, similar to what they said with Protocol T. And the key message, I think, which Dr. Nishant and I have, and I'm trying to say that early intensive anti-VEGF is important for patients in Asia as it is across the world. The ASRS PAT survey is annually done by the American Society of Retina Specialists, and they had participants from 42 retina societies across the planet participating in it. And even they found that aflibercept is considered a treatment of choice for even new onset DME if the cost was not an issue. We all look up at the DRCR net because this is not a strict clinical trial. Some way they also recruit from private practices across America. And it is the fact that aflibercept is recognized as standard of care for DME is the fact that DRCR net also recognizes it, and it is using it in all its pivotal trials which are coming up now. So to summarize, aflibercept is treatment of choice for patients with visual less than 20 by 20, as demonstrated by Protocol T, by the guidelines from society, and by some of these real-world evidence studies. Importance of early intensive treatment, so treat it early, treat it hard, and then you can get robust long-term improvements in vision, and you can reduce the treatment burden to these patients who are in the working age population, so that you can improve the quality of life in subsequent years. And when costs are not an issue, this is a kind of drug of choice for patients even with new onset DME. Thank you so much.
So I think there is enough data, in fact, that not only Protocol T, but all these studies which Dries also has mentioned, that today aflibercept is #1 treatment of choice. And I don't think so even the retina specialists differ in this. In fact, I was questioning a couple of my friends in US and all. Most of them have shifted and from ranibizumab to aflibercept. In fact, more than 80% have shifted in DME. And I personally don't think so that we should stress only in patients with low visual acuity. Even in all grades, wheresoever we have to make a choice that we have to give anti-VEGF. So the advantage low visual acuity, because there's enough to gain there. That is the only advantage. And even if you see protocol, what Nishant is presenting, 1 year, 2 year, there's always an edge of aflibercept. Only thing is the quantum may differ, that's it.
The area under curve anyway would be better,
Yeah.
so it would be beneficial for the patients.
So, Mallika, you want to say something? Or?
Yeah, one thing I wanted to say is that when
Mike.
in cases where there is a persistent, right from the beginning, if you give an injection and there is no response, then of course it makes sense to give 5 monthly injections. But we should not call it loading dose because that has an implication that blindly you would be giving it irrespective. So the point is, if it is not responding, then you don't wait for treat and extend, or you don't wait for 2 monthly. You just give it monthly, and then after 5 or 6 injections, because you know that now, then you can go 2 monthly.
I agree, because I think Nishant was presenting data, of early intense treatment, intensive treatment of,
dose,
because what he was pushing was 3 to 5. And because he tends to say around 28-30% gain by more than one line, and then if you don't give 5, then those you are denying one line gain to those 20%.
See, the other point I wanted to touch, sir, was that you said, I forget now what you were saying. Okay, I'll come back to it later.
So I just wanted to add one thing to what Dr. Lalit said.
I just said that how many of us actually practice this? You see, early intensive treatment, most of us, I think, are fond of giving only 3 injections, by and large. And we do not mind, especially in DME, giving PRN also. Because diabetes being a multifactorial disease, it's not only, one aspect playing a role. It's the control, lipids, hypertension, so many other factors are also there. So most of us practice 3. But you have presented enough evidence that because one line is 5 letters, and even anatomically also similar, around 1/3 or so you are denying if you don't. Yes, Praveen?
So I think I would say that I prefer treat and extend more in DME as compared to AMD, because the underlying disease is not going to go. That is definitely there. I may not always give a 5 intensive monthly injections, but I definitely give till you start getting a foveal contour. Once you start getting a foveal contour, maybe then you can start extending. But definitely more in favor of a prolonged treatment in diabetes. And
I think we should also differentiate,
this kind of result that second year the need for injection drastically comes down.
Yes, yes.
So which is a
So
major
that is
incentive. which doesn't happen in AMD. So
AMD
you
is a
get a
different-
recurrence means you start from ABCD again.
So the point which you
So
had made was-
basically, Praveen, it's not treat and extend at all in DME because your injection in second year is just coming to 2 to 3 or 4, between 2 to 4. So it's not treat and extend really in that sense what we talk in AMD. So yeah, that is different, but it is not a treat and
I
extend.
agree.
You can't call it.
Yeah.
And in third year, you have even fewer injections. So it's not really a treat and extend. So what we were talking was the early aggressive treatment, which in fact very nicely brought out also by Malika, that if you have these cases, which we find majority in our population, I think we should not be counting that 3 here. That is what basically, I think we have to be aggressive and aggressively treat till we get either rid of that or we switch them. You see, that is the question. But aggressive means no, just 3. I think that is where it got stuck from AMD or all the trials. So I think Nishant did make a point about
I agree with you, Mangat, the term loading dose, generally with ARMD, but here it's because the number of injections in the second year, 2.7 or what he suggested, it is just, more like PRN or these are the average number of injections he is saying. So
Can I make a point? We actually don't want to, go into an intensive therapy believing that the patient will not be able to afford. But over time, when we have started offering aflibercept, actually in suburban areas also, the number of patients taking aflibercept is currently around 20-25%. So, and a lot of these patients with intensive therapy, they are happier off in the second or third year. So
Sir,
we shouldn't shy away.
Sir, I remembered the point which...
Before you forget
I made a
again,
list
yeah.
now.
Yeah.
So you had mentioned that even in mild DME you would prefer. So
No, because I said
yeah,
that
definitely, definitely.
even
because
with patients who have good vision, in case we have decided to give,
yes, exactly. Because we know that unless initial affordability is a problem, because we know that it will last longer. So even if we give another drug, we may have to repeat after 6 weeks, whereas if we give this, we may or may not have to repeat after 3 months. So even the durability is a reason.
yeah, durability is a very good reason. Initially, you see, if patient gains, then he does not mind.
Sir,
the problem comes if patient does not gain. If you show the benefit, then he will afford it.
Sir, just one small point, building on what he just said, that very often the doctor himself or herself gives up and saying that, okay, the first couple of injections have not worked, so the third probably won't work, and then I don't want to subject the patient to further injections. But not only early intensive, but even late intensive therapy will also
That's
work.
what
And
he
that is,
stressed. The third three lines he told.
So
the
it
third
is a
line was
chronic
what?
disease, and then it requires chronic treatment, and that is the point that we want to drive across through the discussion.
Raja?
So overall, yeah, I would say that there are a couple of points which are coming up where we all agree. There are some points where there is still some difference of opinion. Where we all agree is if someone is recommending a patient a less aggressive treatment, at least in the first 6 months based on the data, that is gross injustice to the patient. And doctor cannot give up in the early stages of the disease that you have not got 6/6 vision, so there's no point giving any further treatment. What Nishant's graphs showed were improvements in vision, the letters of gain. They were not 6/6, the percentage were getting 6/6. So we should be extremely careful because in spite of, I know retina fellows, after doing retina fellowship, being in practice, they come back on WhatsApp with questions, this patient has not achieved 6/6, patient is very unhappy, should I give further injections? So this is 2 years of fellowship training, and this is nth number of debate. But the point is, if we do not treat aggressively, which I don't want to use the word aggressively, but it's a scientific term. There is a need for treatment, zero tolerance in the first 6 months. And obviously, Dr. Malika mentioned a point, and Dr. Mangat also agrees that if a patient has achieved 6/6 and there is no fluid, Nishant mentioned in his slide, obviously you don't have to give injection at that particular point of time. But we all agree that we cannot tolerate any fluid in the first 6 months, and data shows that beyond 6 months, you may be able to tolerate some fluid as long as there is no drop in vision. That's very important. But the biggest challenge, in spite of having years and years of anti-VEGF, years and years of debate, what the data shows is that it's not as if the doctors don't want to treat the patients with injections. Aditya Kelkar's publication, which I was, showed yesterday, real world data, approximately 40% of patients do not even take the second injection. So look at the steep fall. Someone who is requiring a second injection, 60% of them don't take the second injection. So where are we in terms of second year and third year? First year itself, first month itself, we have lost the battle. One of the ways is, what Dr. Debulal was mentioning, aflibercept being affordable and other drugs also becoming affordable. But the way we communicate to the patient also makes a difference. I think Dr. Lalit mentioned about, all India data. He would have liked to see Indian data also being presented. I think.
Yeah, I was talking to Raja that you see if countries like Australia with very less number of population and patients, they can project and being quoted. Why can't VRSI or we also collect data at least from 5-7 major institutions who have sizable amount of work so that tomorrow Nishant quotes our work also?
That's very important. Yeah. It's our prestige.
Yeah, you were making a point.
Yeah, hi. So no, actually I wanted to just discuss one point about what the opinion of the panel and everybody here. So sometimes even after an aggressive treatment, you would have patients who will have that little bit of fluid or little bit of CME and their vision also improves, but then the OCT is not very great. And you do have at the back of your mind that you want to switch, or even otherwise if you plan to switch for whatever reasons. So how many of you practically feel that, you see, traditionally we just had ranibizumab and, Ozurdex as a switching factor. And so how many of you do you feel that, okay, you would first switch to aflibercept now and not Ozurdex?
So my decision is primarily based on not only OCT.
Right.
It's based on vision and OCT.
Yeah, both. Yeah. I'm just talking about switching. So practically
switching from ranibizumab to aflibercept should be, actually universal, because steroid has side effects as well. And it is not superior in drying effect even. So what is the advantage of switch? Steroid, I think, should be, at least in DME, should be a last resort when you have tried aflibercept, say 5 times or 3 times. Only then you would, because you're taking some side effects, including cataract, raised IOP. So there's no benefit.
So unless there is a contraindication like recent CVA or, other.
And there are some studies which have also, and personal experience, which shows that even if anatomical results are the same between the two, the patient's subjective visual response is much superior to anti-VEGF than to steroid. And this we see repeatedly. Not only objective visual acuity outcome, but subjectively patient always says, no, this was better, even if your OCT is similar. But even OCT I find is better.
So if I feel the vision is improving with one particular drug, then there is no point in switching it, even if the OCT has some residual fluid, because our main guide is the vision.
Yes, if you are asking about VRSI data, we didn't specify the parameters of a case scenario when they are going to switch. Vision is improving or not improving, OCT is improving, but there's still fluid. In 2 injections, almost 50% of them switch if there is no improvement, compared to all the protocol data where they wait for at least 5 injections. In India, we have a lower threshold, and by 3rd injection, if there is no improvement, if there is a reason to switch, almost everyone switches, and they do not wait for 5 injections. And the other thing is, will you switch between anti-VEGF injections, or will you switch between, if you have given anti-VEGF, everyone starts with anti-VEGF, will you give steroid? Almost everyone jumped in that survey. They chose steroid instead of switching between anti-VEGF.
Yeah.
That's the
just building on what you just said. Sometimes improvements, especially in chronic cases, can actually continue over 2 years. So continuing with the same drug also may make sense in many of these. If you've started off with aflibercept and you have seen moderate or minimal improvements every time, it might even continue, and then the person can actually achieve 6 vision.
Practically switching over to aflibercept now has become much easier, especially with the programs and all. But earlier, obviously,
actually, Raja presented the data which was when aflibercept was very expensive.
True,
And
yeah.
that is the time this survey was done. And so everybody switched very fast. So after aflibercept, probably the things have changed. Once it became affordable.
That's a
and
good
it's very
point.
cost.
That
that's
survey
that is
needs
what
to
has,
be
I
conducted
wanted-
again.
Yeah,
And
that
then
was exactly my question, was that how frequently are we switching?
I agree. Aflibercept in our usage was, around 10-15%. Now it is more than 85%, primarily because of affordability.
Yeah.
Previously it was 60,000 plus. Now it is costing economically. Also, it makes sense to
almost
start and finish off with aflibercept. And
So
then the option of switching comes to only steroid. There's no sense to go back to ranibizumab or this thing.
So just
So
to
I, for
add-
one, will agree with what was being
Just
said.
to add, Gagan, one more thing. I think aflibercept is definitely the drug of choice now for DME, even for mild, because it reduces the number of injections. But just to highlight, even in protocol T, after the end of 48 weeks, 30 to 40% of the patients, they required some rescue laser therapy. So we also have to keep in mind that, some parafoveal, if there is a leakage, we can also use some laser that will also further reduce the number of injections in the long term. So probably you can reduce the number.
That is true. I think most of us, it's not a rescue. It's basically just to reduce the number of injections. All of us, I think, after a couple of injections, do FA and identify the areas which can be treated by laser. That's okay. But the thrust of today's talk was take away from the presenters 3 to 5, because mind में जो ingrained है वो 3 है. So वो जो peak उसने दिखाया ना वो यहाँ से ये है तो peak वहाँ पे जाता है तो that is what we learned today, that to maximize in all the 3 sets what he labeled, that poor responders still, then maximum responders you get more 1 line or 28%. I think that is what I think the takeaway from this, that we should, and as Rajesh says, it is the early treatment, intense treatment that should be offered to this patient. And nowadays, because it's economically more viable, we can easily, because our counseling makes the whole impact. What you talk in the first go with the patient, because that time you have to spend more time, and patient, I think, will be compliant if you tell him economically, visually, anatomically, it makes sense.
And sir, just to also add, Dr. Nishad made a very important point. If the vision is not improving, to look for the any structural abnormality, deposition of heart. Probably we can do that before starting the treatment only. You can do a OCT, angio, or see the deposition of heart exudates and inform the patient accordingly.
Yeah, last point.
Yeah, so just, one point that helps in counseling is that telling them, because the first question that the patient asks is how many injections and why should I take? So the point that we generally make is that diabetes is a lifelong decision. So I think the first question should be directed at your physician, that why do I have to take medicines for life?
We are presuming that, you see, we will take care of those 5 factors, hemoglobin, diabetes, hyperlipidemia, hypertension. We presume that this audience is aware of this and should not forget the importance what Aditya was saying.
No, and so that, because they don't want lifelong injections, but then why are you taking lifelong therapy for diabetes? So
because these are controlled data, what he has
See, these injections are not lifelong. All the studies have shown that after 2 years, you hardly need.
Yeah.
No, so that's true, but
all studies have
sometimes
shown.
So I think we did learn a lot from Nishant as well as Dry's presentations, and hopefully most of us should come back with our experiences, and we'll request Raja and Veerasai to have more of Indian data also, and I'll request Bayer to help us in this collection of data so that we can have performance, and then request Nishant to present our data there. Thanks to all the panelists and the Bayer group for having us here.